This is the first in a series of presentations on the topic of radiography in musculoskeletal trauma and repair. The intent of this presentation is to describe the evaluation of the musculoskeletal trauma. By the end of the presentation, you should be able to recognize and describe fractures with respect to location, type, and displacements. And importantly, I want you to be able to distinguish between a traumatic fracture and a pathologic fracture. Radiographic evaluation of musculoskeletal trauma includes a complete description of the bones involved as well as the location within those bones, whether or not the joint is involved, which soft tissue abnormalities are present, and then with respect to the fracture itself, the extent or type of fracture, and then finally the displacements that we identify. This slide is to remind you of the various locations within the bone. On the left of the slide is a skeletally mature dog depicting the locations within the tibia, and on the right of the slide is the skeletally immature dog. When we talk about long bones, remember that we have a proximal and a distal epiphysis, a proximal and a distal metaphysis, and then we have a diaphysis. And when I am looking at the diaphysis, I usually divide that into proximal, middle, and distal diaphysis. When we look at the skeletally immature patient, remember that we have open growth plates, so we also need to consider the physis when we're talking about location. Now, there is no good distinction between the metaphysis and the diaphysis, so sometimes we may not know exactly which is the best term for the location. Let's just see some examples using location to describe where the fracture is. On the left of the slide is a skeletally immature dog. And this dog has a fracture in the distal femur, which is actually going right through the physis. So fracture of the distal physis of the femur. The patient in the middle is a skeletally immature calf, and the fracture that we identify is within the radius, and this is within what I would consider the distal metaphysis of the radius. Some people might call this the distal diaphysis, and either is probably fine. The patient on the right is a skeletally immature dog with a fracture through the tibia, and this fracture I would say is within the mid-tibial diaphysis. When we think about whether or not the joint is involved, sometimes the fracture lines extend into the joint. This is a CAT, lateral view of an elbow, that has a proximal ulnar fracture, and this would be kind of proximal diaphyseal, metaphyseal of this ulna. And if we look at this fracture line, it actually extends into the joint in this area. So this now is an intra-articular joint fracture. This is an example of a horse with a lot of fractures involving the proximal phalanx, a lateral and a DP view. And when we look closely at this fracture, there are fracture lines that are extending proximally into the metacarpal phalangeal joint, but additional fracture lines are extending distally into the proximal interphalangeal joint. So we have intra-articular fracture of two joints. Now, the fracture lines may not extend into the joint, but the joint may have instability. And we can talk about subluxation or luxation. Subluxation of the joint is a partial dislocation. So typically there's still some continuity of the articular margins. So if we look at this tarsus of this dog, there is instability down here in the tarsometatarsal joint, but there is still some overlap of our articular surfaces. And so this would be a subluxation of the tarsometatarsal joint. When we look at the cat elbow on the right, we can see that the ulna no longer contacts the radius, the humerus no longer contacts the radius or the ulna. And so this cat has a complete luxation of the elbow. Now, when we see either subluxations or luxations, we need to assume that there is soft tissue injury, which may involve a lot of damage to the collateral ligaments, maybe the joint capsule. We also need to check for associated fractures. And as an example, the patient on the middle of the slide that had the subluxation of the tarsometatarsal joint also has a fracture involving one of the tarsal bones of the distal row of tarsal bones. This is an example of a dog that has a craniodorsal complete luxation of the left coxfemoral joint. So we can see that the femoral head is displaced dorsally and a little bit cranially from the acetabulum here. Notice on the ventrodorsal view, it's a little bit more challenging to identify that displacement. So this shows you the value of two views. This slide lists the next things that we're going to consider when we're evaluating our radiographs in trauma, such as whether or not there's communication with the environment, what the actual extent of the fracture is, and then beyond that, what is the direction or type of fracture, and then what are the displacements. The list on this slide is not exhaustive, but it will suffice for your stage of training and in our imaging course. Let's start with considering communication with the environment. We will describe a fracture as closed if we do not identify anything that leads us to believe that there is communication with the environment. However, if we identify a skin wound or subcutaneous gas, also called emphysema, or maybe embedded debris, then we are going to actually classify our fracture as an open fracture. In the middle of the slide is a patient that has mid-diaphyseal radial and ulnar fractures, has soft tissue swelling and distortion of the fascial planes, but I do not see anything that looks like a wound, emphysema, or embedded debris. So I will classify this as a closed fracture. In difference to that, on the right of the slide is a patient that also has radial and ulnar fractures, more distal diaphyseal radial and ulnar fractures. And other than having soft tissue swelling, there is also extensive gas within the fascial planes of the soft tissues. I'm not sure that I specifically see a wound, but obviously there has to be a wound to have all of this emphysema. And so now we will call this an open fracture. These are orthogonal views of a tibia and a fibula in a dog that has not only soft tissue swelling at the level of these distal diaphyseal and tibial and fibular fractures, but also has a little bit of gas if you look closely, and then many metal fragments that are throughout the soft tissues, which are fragments of a bullet. So this is an open fracture with multiple bullet fragments and a little bit of subcutaneous emphysema. Next, let's talk about extent of fractures. And we may be able to identify an incomplete fracture, whereas most of the time we'll actually identify complete fractures. Incomplete fractures are fractures that only involve one cortex of the bone that we can identify on the radiographs. On the middle of the slide, I have a tibia from a horse where I can see a fracture line here that is through the medial cortex of the tibia, extends proximally and laterally, but there is no fracture line through the lateral cortex. So this would be an incomplete tibial fracture, and it's involving the mid and distal diaphysis of the tibia. On the right side of the slide is a dog that has radial and ulnar fractures, and if you notice, the fracture lines completely go through medial and lateral. So these are complete fractures of the radius and ulna in the kind of distal diaphysis of both bones. This is another example of a horse with an incomplete fracture, which is not an uncommon fracture in the distal third metacarpal bone, especially in racing patients. And when we look at this dorsal palmar view, I can see a fracture line that importantly is intra-articular. It's going through this portion of the condyle. It extends proximally, but it does not extend out through the cortex. So this is an incomplete fracture of that third metacarpal bone condyle. Now, as we move on to extent, the next descriptions are of complete fractures. First, you can have a simple fracture. So that is just one simple fracture line. You've got two ends of your fracture, a proximal segment and a distal segment. But not uncommonly, we have multiple fractures that occur with multiple fracture lines within the bone. When we see multiple fracture lines and they all seem to kind of communicate with each other or converge at common points, then we call it a comminuted fracture. And comminuted fractures can be described as mildly comminuted or severely comminuted. And mildly comminuted fractures have only a few fragments, whereas highly comminuted fractures have many fragments. We may less commonly identify what is termed as a segmental fracture. And this is a fracture that doesn't share a common point. There are like building blocks or a floating segment of bone from kind of two separate fractures within that bone. So this is a lateral view of the tibia in this patient, and if you notice the tibia, there is a fracture line that's complete here through kind of the mid diaphysis, and then there's a second fracture line that is complete through the distal diaphysis, and so that creates this separate piece of bone that is kind of floating by itself, and so this is a segmental fracture. Now notice this patient also has a simple fracture of the mid diaphysis of the fibula. Next, let's consider the direction or type of fracture. And looking at this slide, I have several different examples of words that we can use to describe our fractures. And again, these are going to be complete fractures. So the first fracture type is a transverse fracture, and this is when the fracture line is perpendicular to the long axis of the bone. So in the mid diaphysis of the radius and ulna of this dog, we have simple, complete transverse fractures. In the middle patient here, we are looking at distal, diaphyseal, radial, and ulnar fractures, which have an angle to the long axis of this bone, and so these are now considered oblique fractures. So we have oblique fracture through both of these bones. If the angle is less than 45 degrees to the long axis, we'll call it a long oblique, so it's really long. And if it is greater than 45 degrees to the long axis, we'll call it a short oblique fracture. The patient on the right has a fracture that we will call a spiral fracture. We have lateral and craniocaudal views. A spiral fracture is also known as a torsion fracture, and that occurs due to rotational or twisting force when weight is planted, and it appears as kind of this corkscrew twisting on the radiograph as it's wrapping around the long axis of the bone. A less common fracture we might identify is a compression fracture. These are more common in the spine, and overall you may just appreciate that there has been shortening of the bone. We may actually see a sclerotic line at the fracture due to the bone compaction. This is a ventrodorsal view of the lumbar spine. L7, if we compare L7 to L6, is markedly short, and if you look in the middle of the bone here, there's this thin sclerotic line, and this is the kind of compacted bone here, and so this would be a compression fracture in this bone. We might also identify a type of fracture called an avulsion fracture, and these fractures occur at the origin or insertion of tendons or ligaments or even potentially the joint capsule. So you really do need to consider what might attach where a fracture is occurring, and oftentimes these are going to be bumps on bones in order for us to classify it as an avulsion fracture. So in this young patient here, this lateral view of the stifle, this is the tibial tuberosity, which has a separate center of ossification, and it has been displaced proximally by the pull of the patellar tendon here, and this is an avulsion of the tibial tuberosity. And then in skeletally immature patients, we have to always be wary of looking for physeal fractures. And physeal fractures are injuries to the growth plate, and they only occur in skeletally immature patients. So you have to have an open growth plate to classify it as a physeal fracture. Unfortunately, we may not radiographically recognize the trauma initially. We may recognize it later when we see problems that can occur due to the damage to that physis. So we can get premature physeal closure and potentially angular limb deformities. So whenever I have a skeletally immature patient and they've had some sort of trauma to their musculoskeletal structures and we radiograph them, if I don't find a problem at the level of the physis, I still like to discuss the possibility of growth plate injury with the client so that we can have the client watch the patient closely to make sure the limb is growing as expected. And then we might even consider bringing the patient back in for recheck radiographs in several weeks to see if we can identify the problem later. When we have identified a fracture involving the growth plates, then we use a specific classification to name those fractures, and that specific classification is the Salter-Harris classification. And listed on the left are the different types. Type 1 is a fracture just involving the physis. Type 2 involves the metaphysis and the physis. Type 3 involves the physis and the epiphysis and is typically intra-articular, not always. Type 4 involves the metaphysis, the physis, and the epiphysis, and is also oftentimes truly intra-articular. And then type 5 is a crush injury to the physis, and this one happens very commonly in the distal ulna. I know that students sometimes have challenge remembering these, and so there is a mnemonic that you can use, which is Salter without the E. So type 1, the S stands for straight across, so that's the physis. Type 2, the A stands for above, so that's our metaphysis and our physis. In type 3, the L stands for lower, so that's through our physis and epiphysis. And then the T for type 4 stands for through everything, metaphysis, physis, and epiphysis. And then type 4, the R, or 5, excuse me, the R stands for rammed, and that's our crush injury to the physis. So that might help you as you remember these different classifications, because I'll want you to be able to assess your radiographs and name the type of the fracture. So this is an example of a Salter-Harris type 1 in the distal physis of the tibia. This is the physis. We can see that the epiphysis is displaced from the metaphysis. So type 1 Salter-Harris fracture. This is an example best seen on this lateral view in a patient that has a Salter-Harris type 2. So there is distraction at the physis and some displacement of the epiphysis. But then when we look closely, we can see that there's actually a fracture line and a small piece of metaphysis that is fractured off. So this is type 2. Here's an example of type 3, and these are pretty uncommon. Again, type 3 is going to go through a portion of the physis. This is the distal physis of the femur, and then is going to go through the epiphysis. So here is the continuation cranially of the physis, and so this fracture line is going through the epiphysis. Not very easy to identify on the craniocaudal view. This is a common Salter-Harris type 4 fracture happening in the elbow of our dogs and sometimes cats. And again, the Salter-Harris type 4 is through everything. So the fracture line is going through the metaphysis here, through the physis. So here's our physis, and then extending into the epiphysis. So this is a Salter-Harris type 4 fracture, and there's some displacement. And then here is an example of the crushing injury, the type 5 Salter-Harris fracture. Again, that happens commonly in the distal ulnar physis. In this patient, that ulnar physis is not a normal appearance. It doesn't seem to be completely open. I want you to compare it to the normal conical shape here and radiolucency that should be present throughout the distal ulnar physis. And then keep in mind the distal ulnar physis and the distal radial physis, they are open for the same amount of time, so you should see them both open on your radiograph if they are supposed to be open. Pathologic fractures occur secondary to an underlying bone abnormality, and they can be due to non-aggressive or aggressive processes. This first example is a patient that has very poor bone quality diffusely. This is a patient that has nutritional secondary hyperparathyroidism, and if you look closely at these femurs and the tibia that are challenging to evaluate due to the poor bone quality, there are fractures through this abnormal bone. So it's pathologic fracture because the underlying bone is not normal. Here's another example of a fracture secondary to a non-aggressive process that we'll call a pathologic fracture. In certain spaniel type breed patients, there is a process that happens where we get incomplete ossification of this distal humeral portion of the bone, the condyle. And so this incomplete ossification leads to the bone not being very stable. And so you can actually fracture through that. And so in this patient, who is still skeletally immature, so still does have a Salter-Harris type 4, it is actually a pathologic fracture secondary to incomplete ossification. We may not know that unless we radiograph the other limb and identify the incomplete ossification, as well as knowing that it is a spaniel type dog. And then these are examples of patients with pathologic fracture secondary to aggressive processes. And remember, aggressive can be fungal infection or tumor. Both of these happen to be primary bone tumors. And so on the tibia of this dog, we can see that there is an oblique fracture through the distal diaphysis. And then when we look at this underlying bone, we see permeative and moth-eaten lysis kind of throughout the diaphysis into the metaphysis, along with some soft tissue swelling. And so this is a pathologic fracture. In this patient on the right of the slide, this is a highly aggressive looking distal femoral lesion where we have a lot of moth-eaten lysis. We have amorphous periosteal reaction. There's cortical lysis actually on both of these patients. And then we have a lot of soft tissue swelling. And this patient also has a fracture line. So underlying bone quality is markedly abnormal. And so these are pathologic fractures. And it is very important to identify these because it's going to affect management of our case. It may require additional workup, special stabilization, and additional therapy, regardless of the underlying pathology. And I also want to make sure that you don't confuse identifying the underlying pathology because of the history of possible trauma. When I want you to call a fracture traumatic, the underlying bone is normal, and then there was some sort of trauma that caused the fracture. But if we identify underlying bone pathology, regardless of if there was trauma, we're still going to call it a pathologic fracture. And then whenever you look at the fractures, remember to evaluate the underlying bone using the fundamentals we've already discussed. Next, let's talk about displacements. And displacements may vary depending on, how you position the patient. But at the time of taking the radiographs, this is how we'll talk about displacements. And displacements at a fracture are described by how the distal portion of the limb is displaced relative to the proximal portion. So we could think about the fact that once there's a fracture, the distal portion of the limb is kind of not really held stable against the body, whereas the proximal portion is still stable against the body. And so that's why we talk about displacements distal relative to proximal. So when we look at this patient, we're going to use both of our views to help us describe our displacements. We either have to have an anatomic or a radiographic marker to help us. And I know that up here in the elbow, the radius is lateral. Down here in the carpus, the ulna is lateral. So I know this is lateral. Notice that these distal diaphyseal, radial, and ulnar fractures are displaced laterally. So the distal limb is lateral relative to the proximal limb. And then on the lateral view, they're actually not displaced other than maybe going a little bit proximally. So we're going to call this lateral and proximal displacement of these fractures. Here's an example of distal metaphyseal fractures of radius and ulna. And here is our proximal part of the limb. Notice the distal part of the limb is displaced laterally. So here's the ulna. So we have lateral displacement here. On the lateral view, the distal part of the limb is displaced caudally. So we have caudal lateral displacement in this patient with these fractures. Here's a dog femur with a fracture. So on the lateral view, proximal is here, distal limb is more caudal, so this is caudal displacement. When we look at the orthogonal view, there's some rotation here, but notice the distal limb, the distal part of the femur, is medial to the proximal part. So this is caudomedial displacement. And then that limb is, the distal part of the limb is kind of proximal to where it should be. So we would also call this proximal displacement. Our discussion in this presentation was fairly general and touched on the most common descriptions for evaluation, so for more complete discussion, you should refer to the reference I've listed here.